Good afternoon, everyone, and welcome to another presentation, part of our Envisioning Equity series. Today, we are excited to have another conversation and discuss how we can address racial inequities and advance equity in our community. My name is Carla Bautista, and I am a second-year graduate student here at the Department of Public Health at Baylor University. I am excited that you're here and just wanted to mention a few things. This webinar will be recorded and you will be able to view it at a later time or share with someone you know. And secondly, if you have any questions at any point in time, please feel free to drop them in the Q&A box at the bottom of your screen. Before we begin, we want to thank our partners. Today was made possible in partnership with the Medical Humanities Program at Baylor University, College of Arts and Sciences, the Center for Church and Community Impact with the Diana R. Garland School of Social Work, and the Office of Baylor University External Affairs. Before we hear from Dr. Spencer, we want to make sure we lay the foundation with some key terms and expand on what these words mean. So what are health inequities or disparities? Health disparities are observed differences in health status between people related to social or demographic factors such as race, gender, income, or geographic region. Health disparities are one way we can measure our progress toward achieving health equity. Health inequities. Inequities are created when barriers prevent individuals and communities from accessing these conditions and reaching their full potential. They are differences in health that are not only unnecessary and avoidable, but in addition are considered unfair and unjust. Health equity. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education and housing, safe environments and healthcare. For the purpose of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect communities or marginalized groups. And justice. Social justice is a view that everyone has a fair and just opportunity to be healthy as possible. So today we will be, Dr. Spencer will be presenting on achieving racial equity and social justice in healthcare, interprofessional and community collaboration. We're excited that you have joined us, and before we have him come on, we want to present our moderators. Dr. Lauren Barron is the inaugural Michael E. DeBakey and Selma DeBakey and Lois DeBakey Chair for Medical Humanities, Clinical Professor and Director here at Baylor University. And Dr. Stephanie Body, Assistant Professor of Church and Community Ministries at the Diana R. Garland School of Social Work at Baylor University. Dr. Body will now present Dr. Spencer.
Thank you. We're so pleased today to have Dr. Michael Spencer with us. He is the Presidential Term Professor of Social Work at the University of Washington and Director of the Native Hawaiian, Pacific Islander, and Oceania Affairs, also at the University of Washington Indigenous Wellness Research Institute. Dr. Spencer's research examines health and wellness among Black, Indigenous, and people of color communities, specifically the diasporic Pacifica population. He also develops interventions within the community that promote health through Indigenous practices and values. He is the co-lead of the Close the Health Gap and Eliminating Racism Grand Challenge for Social Work. He currently teaches courses on research and social justice in the MSW and PhD programs. And we're so excited to have him close out our lecture series this academic year. Thank you.
Good morning. I think it may be afternoon for you, but it's morning for me in Seattle. Hoping that you all are well. My name is Mike Spencer, as Professor Body just stated. And, I just wanted to start off by saying that, I do have actually a pretty deep connection with the state of Texas because I graduated from UT Austin with my MSW many years ago. I look back fondly on those times because, it was actually the first place that I had lived other than Hawaii. I was born and raised on the island of Oahu. And so, needless to say, it was a big culture shock moving to Texas. But despite that, I think it taught me so much, not only about the world beyond Hawaii, but it really connected me with a lot of the different communities that are in Texas. For about 25 years after my MSW, I continued to work with the Latino community, both not only in Texas, but also in Michigan, at the University of Michigan, where I was for 22 years. And I also work with the African American community in Detroit, uh, in Detroit, Michigan, for about the 22 years that I was in Michigan. But most recently, I moved back to the West Coast, to the University of Washington, about 2 years ago, because I really wanted to do more work with the communities that I come from, the Pacific Island communities that are often not even seen or understood very well. Unfortunately, I don't have a lot of time to talk about my own background, but I will incorporate some of that into this talk. And just start off by saying that it's something that I think is very consistent with the theme that we're going to be talking about today, which is how structural racism impacts the health of communities of color. But more importantly, how can we address that and move towards a more equitable healthcare system? So with that, I'll say, I'm a UT graduate, but I'm a bigger NCAA basketball fan. So I'm wearing my green and yellow today. And I'm very glad to present to the Baylor Bears. Before I begin my talk, I usually like to begin with a land acknowledgement. And within this land acknowledgement, I will begin by saying that the University of Washington stands on the lands and waters of the Lushootseed speaking and Coast Salish people. This includes the Duwamish, Muckleshoot, Suquamish, Tulalip, Puyallup, and other Coast Salish tribes. I live on these lands and work on these lands, and I pay real rent to the Duwamish tribe. And I'm committed to creating spaces for all Indigenous and Black, Indigenous, and people of color communities throughout my mentorship, teaching, and research and service. I also want to acknowledge that Baylor University, even though I'm only here virtually, that I recognize that Baylor University stands on the lands and waters of the Huico Indians, members of the Tawakoni tribe that were part of the Wichita Nation, who are the original caretakers of this land along the Brazos River. I also recognize that I, even though it's virtual, am an uninvited visitor to this land, and acknowledge the Huico people, both past and present. So I want to start off by talking a little bit about health and using my own cultural background to talk about what is health. Health to Kanaka Maoli, or Native Hawaiian people, we use the word ola, ola for health. And ola for us is not just our physical health, it is our holistic health. It is the harmonious relationship between one's mind, one's body, and one's spirit. And how do these components interact with the social and physical environment? So for Hawaiian people, health was more than just living. It's always been about surviving, thriving, recovering, and healing, because health is not always guaranteed. There's many things that act as barriers to our health. We talk about those barriers as being ma'i, or illness. And we view illness as an imbalance. Thus, for us, it was the healer's role to find that source of ma'i and to correct it. So sometimes, yes, it was the physical body, and we work towards healing with that through our own medicines, through our own body manipulations, even records of surgery, and such. So it was often physical, but not always. Sometimes it was psychological, and many, many times it was spiritual. oftentimes it was relationship oriented. And we know this, right? We already know this within our context of Western medicine, within the context of Western living. I think most of us in the field of healing and social work or medicine understand that health is more than the physical. And yet we silo health as physical oftentimes and ignore the psychological, the spiritual. So if we are to resolve OLA, if we are to resolve our health, then we need to work together and adjust our training to be more collaborative and interprofessional. And I believe, and this is going to be my thesis hypothesis here. And hopefully throughout the course of my presentation, you will see how we can restore our OLA through collaboration and interprofessional practice. I want to mention the Affordable Care Act because, as you folks know, it not only mandates access to healthcare, but also changing the system that people access. So that, one of the criticisms that I've always had of the Affordable Care Act is that increasing access alone to an unequal system might only exacerbate inequality unless system change happens. And the Affordable Care Act not only calls for it, but provides resources for it. Yet we haven't really seen ACA move in that direction. We've seen it, and we've seen people focus on access, getting access to it. But if we don't change the systems that have historically been unjust to our communities, increasing access to an unequal system may only lead to greater inequalities. So I now want to turn to racism, which is going to be sort of the central focus of my talk today, and talk about racism as a form of ma'i, a form of imbalance within our society. So racism, it strikes us at the very source of our well-being, our ola. Obviously, we've seen how racism can impact the physical body by the killings of people of color that we have been viewing, the violence against people of color that we've seen on the streets. All of these things we hear about on a weekly basis. Another Black man has been killed, for having air freshener on his car window. These are the kinds of stories that we hear over and over. We understand it's physical, but it goes beyond physical. I look at my community, 50% of my community, the Native Hawaiian Pacific Island community, is in prisons, which is, 50% of the prison community is Native Hawaiian. It's clear that it's physical, but it goes beyond that. It goes beyond, it touches into our psyche. All of these things obviously impact not only us physically, but mentally. But, as I've been saying, it also affects us spiritually. And you may ask me, what do I mean by spiritual? Spirituality comes in many forms, particularly in BIPOC communities. It can take the form of Christianity. It can take the form of another religious community. It can take the form of an individual level spirituality. But for me, when I talk about spirituality, I talk about it as the connection to my culture. Because for me, that's basically the crux of who I am and how I see myself and how others view me on a daily basis. So for me, my culture and my connection to my culture is how I define my spirituality. There's an increasing recognition that racism is ma'i, that exists within our community, and that we need to make change. And this is happening on a national level, which is great to see, right? We have the American Psychiatric Association being one of the first major groups to put out an actual statement of apology for its years of racist practices. And, I believe that this is something that other fields need to look into. Um, and I challenge social work and medicine to be the leaders. Just a little bit about BIPOC histories, because I don't think that we need to spend a lot of time on this. Yeah. Most of us understand the histories that people of color have experienced, whether it be invasion, colonization, genocide, ethnocide, slavery, Jim Crow, and major human rights violations here on this continent and throughout the world that the US has inflicted on others, as well as other European nations to communities across the globe. This is part of our history. We know this, we understand it. It is reality. It will not change, but there's things that we can do about it today. This has been a crazy year, needless to say, for all of us. I know we all wanted to turn the page on 2020, and I'm glad that we did. But we need to look at 2020 as a year to remember for a number of reasons. One, the COVID-19 pandemic and the impact that it had on communities of color, where disproportionately these communities were impacted, not only by exposure, but also hospitalizations and deaths. And so these are major considerations. In the state of Washington, people almost don't even realize Native Hawaiian and Pacific Islanders exist here, except when COVID hit. And we were the ethnic group that was disproportionately impacted. We have less African Americans in our community, so the impact was lower in those communities, but we have a lot of Native communities here in the Pacific Northwest, and those were all disproportionately impacted. We remember 2020 for the senseless murders, and I'll just name a few victims here, but we know that there are many, and they're continuing to come forth. We are continuing to hear about these murders on a daily basis, it seems. A lot of what we saw this past year was the renewal of an existing movement, which was the Black Lives Matters movement. We saw people doubling back on the notion that racism doesn't exist and seeing it with their own eyes and coming to a realization that enough is enough. People should not be treated this way, and that the best of us should assure that these kinds of things never happen within a civil and engaged society. We're seeing an increase in anti-Asian hate crimes, and to say that this is new would be ignorant, because anti-Asian violence has been a part of our US history from the very beginning, and continues to be so on a daily basis, and just to give you a little story of how this impacts, right? So while I identify as Native Hawaiian, my father's Native Hawaiian, my mother's Japanese. So I'm in what we call in Hawaii, I'm Hapa, I'm half and half. But I was down in the International District here, which is our community where Asian communities live, our Asian enclave. And there was a man who was screaming and yelling and throwing a tantrum. He was a white male, younger. And I wasn't sure if he was mentally ill and homeless, as many of our homeless congregate in our international district, but or if he was going to hurt someone, because he was screaming at people. He was screaming at people in the windows of restaurants. He was throwing things. violently on the ground, and I wasn't sure if I should call 911 or not. Now, the likelihood is he was homeless and he was mentally ill and he was not intending to hurt Asian people specifically. But the impact that it had on me in that moment of processing, what should I do here? What's going on here? Why is this happening? What can I do about it? Do I call the authorities, or do I approach this individual? These are things that, on a normal basis, I would probably be able to diagnose as homeless and mentally ill. But because it was in the international district, I had to pause. That affects me physically, spiritually. It affects me psychologically. There's also this renewed and growing interest now, because of all that we've seen in 2020, to finally address racism. And I believe that the conversations are now finally moving beyond how do we change individuals to how do we change systems. And that's one of the things that I'm most excited about 2020, of what 2020 taught us. Structural racism. So my good friend Gilbert G uses the analogy of an iceberg to talk about racism and structural racism. Racism, the everyday racism, the racism that we see, the implicit racism, the interpersonal stuff is up there on the surface. It's what we can see as far as racism. But what underlies beneath the iceberg, the foundation of that iceberg, the piece that's holding that whole iceberg together is what is structural. And that's where structural racism exists, right? It's a macro level system. It's part of the social forces that exist within society, within our institutions, in our ideologies, in the processes that we interact with one another. All of these things either generate or reinforce inequalities, oftentimes among racial and ethnic groups. These structural mechanisms, the thing that's most lethal about them is that they do not require us to act or have any intent. It just happens. It's a train that keeps rolling. And all we need to do is do nothing for that train to continue. What we need to do to stop that train is to actively get on the train and press the brakes. Just a few examples of how structural racism then gets how it gets seen within society. This is where just the tip of the iceberg exists, right? The social segregation of structural racism leads to inequalities in terms of our residential areas, our schools, our workplaces, our places of worship. All of these things are places of which we see social segregation. Some of this is historical with regards to redlining and such, but some of it exists today with the unequal funding of school systems. In terms of healthcare facilities and who is allowed to go to certain healthcare facilities and who ends up going to other healthcare facilities because of issues of access or issues of lack of income or lack of resources. Immigration's another example of structural racism that exists within the US from the standpoint that our country has always had immigration policies that have been unequal, whereas people of color were oftentimes subjected to forms of immigration that were not considered legal by the nation that we're trying to immigrate to, but other people are given free access to immigration. Also too, the different ways in which people have been treated once they enter into this country, the ways that they're treated at the border, how they're welcomed into this country. We've seen differences in how people are treated through the immigration process historically, and as we know, continues today. Criminal justice, this is a system that we know has been unequal for a long time, and that we continue to enforce laws and policies that continue to perpetuate those inequalities. Um, though I think recently, I can't remember if it was our governor, I think it was our governor here in the state of Washington. He pardoned a whole group, a whole class of individuals who were imprisoned for minor drug crime. And, you can imagine how many people those were, and how many of those were people of color. Um, Computer and internet access, with COVID-19, that's another area where we saw structural racism rear its head. I've been doing work on racial inequalities in schools, and what do you think happened when COVID-19 happened, right? Who were the kids that who were able to continue to engage in school? Well, it was those same individuals for whom for whom they had greater school access to begin with. Schools that understood who they were culturally, respected their culture and respected their language. And those students of color, oftentimes in predominantly white institutions, who did not have that advantage or have the access of being able to have schools distribute Chromebooks or things of that nature. I also want to, highlight the fact that addressing racism isn't just something we need to do for people of color. A new book by Metzel speaks to sort of the notion of how racism impacts all of us, including white people. And he, in his book, talks about how some of the policies that have been enacted that were intended to hurt people of color actually hurt white people who were voters, who voted for these very policies, which threatened all of our well-being, including cuts to public schools, delays in the Affordable Care Act, anti-gun safety regulations. And, all of these things, we think, okay, well, we can rationalize where these might come from, but the consequences also need to be looked at, right? Where white gun suicides have soared in these years. Life expectancies of white communities have begun to fall. And school dropout rates actually have increased in this time for white communities. So, we really need to think about these policies, not just as policies that impact communities of color, but it impacts all of us. Just as we talk about climate justice here, climate justice impacts all of us. The life of our land is tied to the life of our people. If our land is dying, our human race will die. If you want to talk about indigenous knowledge, that's about as indigenous as you get. This is known fact for multiple generations going back thousands of years. If we kill the land, we will kill the people. Okay, and so climate injustice does impact all of us. It does currently impact BIPOC populations the most because we're directly exposed to those toxic hazards and particulates. And this even goes beyond socioeconomic status. But I have to emphasize climate injustice affects all of us. Racism is also something that's very chronic. It's in the air we breathe. It's in the water we drink, both literally and figuratively. And we can look at communities like Flint, where hundreds of thousands of young people were exposed to contaminated water. And yes, Flint is a Black city. So many of these kids were Black, but they were not all Black. It's not a completely Black community. It's about 60 to 70% Black. So it hurts all of us. And the funny thing about it is we all pay for it and we support it on a daily basis. You know, our taxes, go to support and pay for police, which promotes and supports police violence. Our money goes to military, which has destroyed lands. Um, Whenever we buy something at the store, if we unconsciously buy goods, uh, and other things, as consumers, we have our own responsibilities in terms of understanding where we put our money, because if money talks, where we put our money can make a difference in terms of this world. I put a lot of information on these slides, and my understanding is these slides will be available to you. So I'm not going to talk about each point here because I feel like this is literature that exists out there. Much of it done by one of my mentors, David Williams. When I was at Michigan early on in my career, I was fortunate enough to work with Dr. David Williams, who was really who was groundbreaking in terms of his work on looking at the relationship between racial discrimination and both physical and emotional well-being. He talks about racism being related to a bunch of disease states, everything from cancer to diabetes, as well as pre-clinical indicators of disease, body mass index, not diabetes, obesity, et cetera, et cetera. Discrimination is also associated with a number of different psychological outcomes, depression and anxiety specifically, and that comorbidity between two or more of these illnesses is much, much higher in terms of it is highly associated with racial discrimination. I put this quote here by Kamara Jones, who is, for many of us know, of NIH, and has been a huge person in terms of looking at race and health, and particularly healthcare. And she talks about racism as a system of structuring opportunities and assigning value based on phenotype or race, the way we look. It unfairly disadvantages some individuals and communities and unfairly advantages others. And it undermines the real, and this is the part that I think for me is the key to this phrase, to this quote here, and undermines the realization and the full potential of the whole society through the waste of human resources, right? So we want to reduce waste in society, right? Okay, that's understandable, right? We want to be as efficient as possible. This is the world that we live in. I'm trying to take a very rationalistic approach to this, right? We want to have if we want to have an efficient society, a society where we maximize the resources that exist, maximize our knowledge, maximize our experiences, maximize what we know so we can create a better whole society. If that's the case, why would we waste people, right? Why would we waste people? Racism as a stressor. Besides sort of the attitudinal racism that people experience, the conscious or unconscious, implicit bias, the behavioral racism, or the colorblind racism, a lot of these things cause stress for us. It is stressful when people tell me that they don't see my color. Why? Because it's clear and obvious that I don't look the same, and I actually derive a lot of strength from who I am. And so to say you don't see me says you don't see who I am, and you also don't see the problems and the concerns that my community has because you don't see me. This is modern day contemporary trauma, and it's derived from this cultural historical trauma that's also been passed down intergenerationally to us. Some people have called them soul wounds, others have called them cultural wounds. but there are wounds that exist within our community that um, have evolved and have changed and now exert themselves in much more different and contemporary ways, like the colorblindness, like the implicit bias that we see. While we may be reducing behavioral racism or discrimination, we're also seeing that on the rise now. You know, I thought we had been making some progress within our society, and suddenly we've taken a big step back, and now behavioral racism or discrimination has become something that I think people have become a bit more brazen to you know to speak to. I think there was a point in which people felt like, let's just not talk about those things. Well, now people are becoming a little braver, and they're wanting to speak out and to speak in ways that are bigoted and racist. And we as a society need to decide, is that what we want? Is that the direction that we want to go? Racism in healthcare. I want to just recommend Unequal Treatment. It's not the latest book that's out, but it's one of the most comprehensive, and the first, really. It was seminal in speaking to racism in healthcare at the institutional level, the financing level, and at the clinical encounter level with regard to provider bias. And studies have shown that provider implicit bias at the provider level is actually quite high. And that all of those things have implications for how we provide healthcare services. As you can see, there's just issues of access in terms of insurance, but there's also issues of receiving poor quality care. And some of these things are tied to issues of provider bias, but they're also tied into our financing system as well as other structural factors. On average, people receiving not just poor quality service, but in some cases receiving worse service from the standpoint of moving more quickly to evasive surgeries like amputations, or people of color receiving far higher doses of psychiatric medications or antipsychotic medications as earlier course of treatment than others. Finally, I want to talk a little bit about the WHO's 6 building blocks of a health system, because the World Health Organization did create a model to look at how we can have functioning healthcare systems. And interestingly enough, these coincide very well with our own, in terms of the ways in which we can look at how racism impacts healthcare. So I use the WHO model as a model for speaking to how we can eliminate racism in healthcare. And I'll start with the first, which is service delivery. Healthcare providers have implicit bias, as we have talked about, in terms of greater positive attitudes towards whites and negative attitudes towards people of color. This is something that has been documented, and it actually is even the latest research continues to support this. And you might say to yourself, wow, that's crazy. How can that be? Well, actually, we all have implicit bias. Every single one of us have implicit bias. It is something that we are taught. It is something that we're socialized to from the day that we're born to the day that we die. All of the sources of information that we bring into our psyche, whether it be through our upbringing, our parents, our grandparents, our daily interactions, our workplace, all of these things contribute to our implicit bias. And so, to say that most people have implicit bias is actually kind of a misnomer, because we all do, and we all need to confront that issue. And it is significant related to things like patient-provider interactions, to treatment decisions, treatment adherence, and patient health outcomes. The various approaches to reducing disparities within social work and medicine have often centered have not been centered on the root causes of racism and white supremacy, but it's more often been focused on behavioral change on the part of BIPOC individuals. So when you look at issues of, for many years, I did the research on diabetes, and looking at some of the guidelines for diabetes and behavioral change, none of which, when you look at programs like the diabetes prevention program, none of them address structural racism. None of them address the stressors of racism that exist within society. Uh, all of them are focused on how to create individual level change, right? How to eat better, how to go exercise, and some of these things that we take for granted is access to leisure time activities, access to healthy foods, traditional foods being no longer available to people. One of my traditional foods, a starch that actually is lower in glycemic level, which is taro or poi, it's not something that's readily available anymore, even in Hawaii. And in Hawaii, to get poi is very, very expensive because why? People hardly grow it anymore. Whereas before, we produced all the taro we needed for all of our people. Most of those lands are now gone. The water, if the lands exist, the water have been diverted for other purposes, and those lands are now fallow. This has happened with Native American tribes. How do you kill a race of people? You take away their water and their food. And this is what we've seen over and over again. Yet we come back to these communities and tell them to change their behavior and eat more salad, eat more vegetables that are foreign to them, because you've destroyed their original food source. And we have to stop doing that. We just have to stop doing that. Change required by our healthcare systems, right? And designing an effective healthcare system. How can we do that? This is one of the things that a recent report by that was a consensus study by a group of social workers that looked at healthcare activities and integrated systems, and they talked about this model. And I actually converted this model. I've taken it was a generalized model for health equity, and I'm putting an emphasis on racism here, but really it's starting with awareness, and awareness that racism is a societal problem that impacts the well-being of all people and exists in our everyday policies and practices, okay? So we need to start there. We need to build that awareness that this exists. This really does exist. And I hope that most of you do not have to continue to prove that, because I'm hopeful that that's something that we can move towards level number 2. Right? Which is beyond awareness, which is now looking for adjustments. How can we make adjustments to the system that might address these inequalities and provide assistance to those systems requiring greater support, right? So but we have to be aware that there is this problem in everyday policies and practices, right? And then third, are these aligned with the anti-racist aims of our organization? This assumes that your organization does have anti-racist aims, but I think that comes with step 1. Finally, advocacy for ongoing change within the system to assure that the changes are not only adapted and implemented, but also sustained. And from a researcher standpoint, I also say evaluated. But this is a wonderful model for us to think about, a wonderful framework for us to think about in terms of how we can make changes on an everyday level to the policies and practices that impact us. Another area that is cited by the World Health Organization is workforce development. And workforce development, when we talk about that today, we're talking about interprofessional education, but we're also talking about team-based care. And, one of the things that we need to begin doing through interprofessional education and through team-based care is to develop this commitment to social justice, to develop our anti-racist aims within our own practices, and to do it as teams, to do it interprofessionally, because each of us bring knowledge to systems, each of us bring knowledge of our environments, We bring knowledge of ourselves as well as knowledge of the healthcare system, right? So working together. Anti-racism, anti-bigotry should be core content. It should be integrated into every course. I think that we've always talked about, should it be core content? Should it be integrated? And I've come to the conclusion that this is so important that it needs to be both. It really needs to be both. You need to have core content because you need to establish a foundation. And then it needs to be integrated upon and scaffolded and built upon in every course. We also should acknowledge that how our own socialization into white supremacy permeates our understanding of the world and therefore our practices. Um, Content should include the process of unlearning and developing new and innovative ways that our former practices and policies can be reconceptualized. Yeah, so this should be exercises that we do within our classrooms, from an interprofessional standpoint, from a team-based standpoint. How can we look at current systems? How can we diagnose inequality? And how can we create new systems, unlearn old systems, and create new policies and reconceptualize new systems? And then we must also be encouraged to innovate, to go beyond just cultural competence and attitudinal change. And really, innovation is going to be key here because this is a growing area. World Health Organization talks about health system information, prioritize monitoring of healthcare systems within their own institution. This is something that even within the university here, University of Washington, it's very difficult for me to get information on race, racial status of faculty, of staff, of students. And why is that? Well, basically they don't collect that data, or they don't care a lot about that data. Or that data is behind multiple firewalls. And I think that what we need to do is we need to start looking at our own data, which means we collect our own data and we have to look at our own data and we have to look at inequalities and we have to think about where is it that we can make change? Social epidemiologists, as well as other professionals like myself, as well as community members and patients, we understand why some of these things exist, and we can work together to address some of these issues. Private-public partnerships can be established to look at a digital infrastructure. One of the things that we've learned from COVID is that these dashboards are pretty useful for getting information out, particularly around inequality. And we can do that on an everyday basis. Within our institutions, it's really not that hard to do. And we can monitor our own systems for inequality. Equitable access. Again, I've already talked about how increasing access to unjust institutions does not reduce inequality. So what can we do? We have to take into account and take accountability for our own histories with racism as institutions. And that's, one of the things that I've been not only trying to do within health, but also within higher education as well, to look at and to take some accountability for what we have done historically as institutions to promote racism, and then to develop some potent strategies to reconcile and atone for these actions. A lot of our talk has been around costs and cost effectiveness as driving our systems. And I think that we need to go beyond cost effectiveness and we need to think beyond how much things cost to be innovative. Obviously, there's always a balancing act between cost and effectiveness. But if it is our lone driving factor, then I can assure you systems will continue to be unequal. Financing systems. We have the Centers for Medicare, Medicaid Services, the CMS. Currently, right now, we really don't know what social care means and what Medicaid can pay for. To some degree, we do understand these things, but there are still a number of services that we know work that are not covered. These include culturally appropriate services and culturally grounded services. Community health workers, for example, this is an area where I've done work in for now, for about 25 years in terms of community health workers and peer support people. These people and peer specialists in mental health are paid for, but not community health workers. Oftentimes they're still funded through waiver programs and other roundabout ways. Oftentimes, there are, some aspects or some funding available for culturally based programs, but those are very specific calls and they're specific programs and not clearly defined under Medicaid or Medicare. And this also includes like some of the traditional healing that we've been doing in Hawaii as well. Hula classes, dance classes that are culturally rooted as forms of physical activity and exercise. Clinicians and administrators are also more likely to implement interventions if they do improve equity, and if those efforts are paid for, right? So they're more likely to implement them if they're paid for. And then finally, we need to align our incentives to reduce disparities, and not just, I think right now our incentives are primarily lined up, not necessarily for that. Leadership and governance is another aspect of the World Health Organization and World Health Organization framework. And a lot of our leadership has been coming in the form of what we call DEI, which is diversity, equity, and inclusion. I use that as opposed to DIE, which is what we've been experiencing: domination, individualism, and exclusion. Most of these DEI efforts are underfunded or unfunded and often relies on the labor of people of color as educators. So while they do have their advantages, they alone are not going to provide adequate leadership unless those things are taken more seriously. Recruitment and retention of providers of color, practitioners who are trained, and not only trained for service, but are also trained in leadership. Yeah, we need to start training people for leadership, and we need to start mentoring people for leadership. We need to continue to implement models of shared power through team-based care. And we need to start including the communities that we work with. And this is where I really want to emphasize is that, too many of our interventions for addressing health disparities ignore one major factor, okay? And that is that oftentimes communities and healthcare systems do not exist within the same realm, okay? In fact, they exist within very different and conflicting environments, and that there is a very, very little overlap between those two systems. And what does that then, lead to, right? That leads to social norms that individuals have internalized and institutional racism that just promotes distrust between these communities and really fuels the conflict, right? One of the things that we want to do is, go back to this slide, is to increase the overlap between the community and healthcare systems, increase the communication between those two, increase interactions with those two. Community health workers bridge those two systems. And that's why I love community health worker models. But designating individuals who have little power and who are not paid for by the system to be your go-between is not adequate as far as addressing racism within healthcare. It may be adequate as far as increasing access, but it may not necessarily be adequate to reduce structural racism within systems. At least that is my argument. Continue on interventions, right? Most of our interventions are based on Western-centric theories. of behavioral change, behavioral strategies, primarily tested upon predominantly white populations. We've moved more towards interventions being tailored to care for individuals and their cultures, right? So, sometimes we call that putting a feather on an intervention, for Native Americans, putting a feather on it and calling it Native American. I've been a part of NIH review committees where people were introducing a culturally tailored intervention where they essentially just changed the names and pictures. These are ways to tailor, but they're not very effective, right? We need to move beyond that. And we need to think about how we can culturally tailor interventions that are more culturally centered and culturally grounded within the community. Interventions that emerge from the local community promote community empowerment. It promotes cultural values and practices. It promotes capacity building, and it also promotes our ancestral wisdom, which is holistic, and it is also accessible. So I just want to end with just a couple of examples here from my own work, because my own work in this area has been very uplifting, primarily in terms of it allowing me to go home and to do work with my Native Hawaiian community. So I want to show you a picture here. The first project that I'm going to tell you a little bit about is a project where we are integrating Native Hawaiian healing practices into primary care. Our healer here, our kahuna la'au lapa'au, her name is Lena Ala. And I show you her picture because a lot of times when people think about Hawaiian healers or Polynesian healers or the kahuna, they have this image in mind. And I like to show Lena Ala because Lena Ala is just a sweet woman who is very knowledgeable and loves to teach and loves to share, and is one of our treasures in Hawaii. And she is teaching us in this picture how to make a bunch of cleanses for us so that we can clear out our systems and so we can heal our organs within our body. Another project I should say too, going back to this. So some of the things that have come out of our work in terms of integrating a healer, at first providers were a bit skeptical, as you might imagine, open-minded, but skeptical, right? Open-minded. But about a year into the process, they began to realize patients came in to see the healer and not them. Patients showed up for appointments because they did not want to miss their appointment with the healer. Patients talked about how wonderful she was and how she brought culture into the clinic. So the providers started to see a benefit from it, and they started to, even talk about, prior to this, if it wasn't evidence-based, I don't know if I would recommend it to my patient. But after seeing what, just the spiritual growth of our patients, that they recommend it, they basically say it doesn't hurt. In fact, it kind of helps people in these other ways. So that's ma'i, right? That's ola, mind, body, and spirit. It's an intervention that goes beyond. Look at the people in the picture there. Look how intent they are in terms of learning and creating these medicines. Look how interested they are in it, right? These are patients of the clinic. And the one on the left was one that I interviewed. And, one of the things that she said was, I never knew my ancestors were so smart. I didn't know that we knew all of these things, and that Western medicine is only catching up to us. We knew all this stuff a long time ago, and I'm so proud to be who I am and to be the descendants of such great people that had such great wisdom and knowledge. That is the outcome I am looking for in terms of, addressing ma'i and promoting ola. Another intervention, this is our intervention using aquaponics systems. So aquaponics are systems where we have grow beds at the top and we have a fish pond, a fish tank at the bottom, and we We run a motor so that the poop from the fish tank goes up and fertilizes the plants, and then removes the ammonia and returns the water filtered for the fish to keep them healthy as well. And these are backyard aquaponic systems. We have distributed over 80 of these systems now. The people who are using these systems now they're individuals who live in rural areas, who live in food deserts and don't have access to a lot of fresh fruits and vegetables. So we're allowing them to not only grow fresh fruits and vegetables in their backyard, but they're also able to grow fish, right? Because fish is also difficult to get now, because our traditional fishing lands have, really have, a lot of them has just been barren because there's no more seaweed in the water. The seaweed, you need to have brackish water in order to have seaweed. And when you divert the fresh water from our communities to other communities, then the water becomes too salty to support seaweed and fish, small fish, and big fish eat small fish. So again, you disrupt the food chain by displacing people. And most people don't even think about this, right? People on the other side of the island are not thinking about where their water comes from. It's not their problem, right? But others have to live with the consequences. And so we work with them. And as you can see, these systems are very popular. Everybody wants one. And we use Hawaiian culture to talk about how this represents our ancient land management system called the ahupua'a, and how mea'ai, or healthy foods, was always part of our community. It also provides peace and relaxation for our people as well. And we saw blood pressure go down for people who had these aquaponic systems. So again, towards solutions here, right? We have to begin with the notion that health and healthcare is a human right and a social justice issue. To reach our outcomes, we have to bridge the big divide between healthcare systems and our community environments. We need to have our healthcare systems examine their own inequities within their systems, and then engage in partnerships with community organizations, in dialogue with patients, and not just patients who've been hurt, but those who are not patients, who have been distrustful of the system. One of the interventions that I had that I thought was really successful with providers was we did residents. We went to local health fairs, and I brought residents, and I asked them to come and sort of staff the booths and just be available to ask questions and meet the community. And, a lot of them came back and they were like, wow, I didn't realize, wow, the community is so cool here, All they knew were the patients that they saw and people who were, presenting illnesses. They didn't even realize who the community was, what richness they could bring in to their own personal lives, let alone to informing a dialogue around reducing racism. One of the examples that I want to give is at one of my former institutions, I was asked to do a consultation around community engagement. And one of my first recommendation was, well, first of all, you have no community engagement. People are given very tokenized roles as members of an advisory board. Nothing that they say, so I interviewed advisory board members, right? Nothing that they say, is heard. They feel like, it's just all about the money and getting us enrolled into studies without much explanation as to why that's happening. So what I suggested was, because they were in the process of hiring a director of community engagement, I recommended that not only that they hire somebody who had done community engaged research, you think that would be an obvious one, but also potentially to have a co-director someone who is a community leader, someone who can share that responsibility with you, and not just a provider, you know? Um, and not only was my report uh, torn apart, but it was, it was being picked apart for other reasons. But I knew the reasons were because I was making some strong recommendations. They ended up hiring someone with zero community experience in community engaged research. It was a white male. Not to say that white males couldn't do the work. I did not advocate necessarily that it had to be someone who wasn't a white person. I just really wanted someone who was a community engaged researcher, someone who had some knowledge of the community. They didn't do that, and obviously they didn't make any other changes to their governance structure. Um, and this is where we're at, right? We don't listen to one another, we don't. And what happened was a few months later, that individual actually resigned. And, they certainly didn't come back to me for help. And I'm don't even know where that's gone. And I'm glad to say I don't know. Uh, Reconciliation, right? So this is, I think, a model that we can utilize. And I'm going to end here. For the four aims of reconciliation. And a lot of these coincide with what we've already talked about, right? Which is one, confronting the impunities of the violations or the truth, right? We need to get down to truth. We need to have an awareness, recognition, and the dignity of victims of human rights violations as citizens and as human rights bearers. So these people, we need to recognize that all people deserve the dignity of not being victims of human rights violations. And that's mercy. That's showing mercy. Restoration of citizens' trust in state institutions, especially those charged with guaranteeing our fundamental human rights. That is an apology state. And finally, the prevention of future serious human rights violations. That's reconciliation. So, with final thoughts here, yeah, we need courageous leadership, and we need support from multiple sectors to do this. It's not going to happen overnight. It's going to take a while. We are going to need cross-racial coalitions. No one can do it alone. We need white allies. We need allied organizations, and we must continue to bend the arrow of justice towards health and well-being, towards Ola, and remove Ma'i from our communities. And we can do this through our own interprofessional and community collaborations. And with that, I'll say thank you.
Well, thank you so much, Dr. Spencer. That was such a wonderful presentation, helping to close out our time this semester by really connecting so many pieces, that it's not just the health of individuals, mind, body, and soul, but thinking about the health of the community, the health of the land, and the various ways we have opportunities to change our systems. So thank you. So we have a question from our audience. Thanks for the highly informative presentation. What types of programs should organizations implement to build relationships with Black, Indigenous, people of color communities by going into the community to be with the people who live, work, and play where the organization is located?
Yeah, I mean, there are so many ways to do this, right? I mean, one of the ways that, for me, that I've always felt pretty comfortable with is just essentially being there. Being there. I know it sounds kind of weird just to be there, but when you show up, they say showing up is 80% of it, right? 80% of the effort. It's actually amazing how many times people don't show up, and don't show up repeatedly. And that's the first thing that I would suggest, is to show up for the community. So when the community has events, show up. When the community is doing things, show up. Um, if this is something that you want to be a part of, then truly be a part of it. Don't helicopter in and try to rescue anybody. No one wants that. You know, you make the effort and show up. Um, I found that to be most effective. But obviously there are much more structured ways to do that, and a lot of the work that I've done throughout my years is in the area of intergroup dialogue. Essentially, it's grounded in nonviolence theory, and it speaks to how can we nonviolently communicate with each other to promote a greater sense of community and wellness, um, collectively, you know. And so dialogue has been very central to my work as well. When you have community advisory boards, right? You oftentimes we bring them together. We have meetings once a month or quarterly or whatever we do, but that's not enough. That is inadequate if we want to transform systems. I'll stop there.
Okay. Well, my colleague, Dr. Barron, also has some comments and questions to ask. So I want to ask her to jump in.
Yeah.
Okay, thank you, Dr. Body. Dr. Spencer, thank you so much. I want to confess that I know so little about your culture being here in Texas. I just know so little because that's just very, geographically influenced about the different communities, obviously.
Yeah.
But you mentioned dialogue, and I am so intrigued about interprofessional dialogue. I'm a family physician. I have to work with teams. I can't do what I do without a social worker as my partner every day, all day long. But I have been, and I understand the value of these collaborations. We can't know everything. I used to take my residents to the pharmacy to show how they made TPN, and the pharmacists were so happy that somebody brought them there, right? But I've been a part of conversations with other professionals that seem to center on the scope of practice or the boundaries of the profession, rather than what we profess we're called to do. So I wonder if you have any wisdom for me about those kind of conversations with, interprofessional dialogue.
Yeah, she's. Yeah, this is my life's work, right? I wish I can say that I had the magic bullet, but it's an ongoing effort. So the work in dialogue has been going on, as we know, for many, 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 many years. And even before it appeared in the academic literature, I'm sure that it's existed in some shape or form, where people resolve conflict through intense and emotional dialogue, and not necessarily to say it has to be emotional, but we don't ignore emotions in dialogue. And I think that's the piece that I think a lot of times is difficult to break through, is that we tend to think emotions are not rational. But emotions are very much a part of who we are, and they make a difference to our patients. So if we don't address the whole, right, we're ignoring some very important things, and I think just grounding ourselves in that, for me, as part of our dialogue, obviously talking more specifically about how we every day perpetuate these kinds of behaviors, is important. But I think, especially for people who maybe tend to think in terms of boundaries or professions, thinking about the data, and looking at the data, that one's hard to hard to deny when you see, okay, this is what our patients are saying. This is what our data looks like. This is who we serve. This is, and I think that might be another avenue, because I don't think that people, most people don't want to believe they're racist, right? Or that they hold racist beliefs. And I honor that. I honor that. I begin by honoring that, and to say, if that's who you want, if that's the image of who you are and who you want to project and who you want to be, then I honor that. And I want you to be that person. And I will work with you to be that person, because right now you're not, and I'm not. And that's the other part of it, right? Is like, and I'm not either. I'm working on it too, and there's a lot of things that I have to do to be a better ally to other individuals, like to women, for example, that I haven't always been a great ally to women. I haven't always been an ally to the poor. I mean, there are other ways in which I have not shown up, you know and so not just putting the responsibility on others, but to say, this is a shared effort. This is something that is baseline across all of our professions. Do no harm, right? Do no harm. That's where we all begin with. So let's start there. I don't know if I answered your question, but if you were to bring me down there to do some work with your group, I'd probably start there.
Okay, thank you. We have a question from our audience. They're interested in your recommendations on equity programs. Would you recommend an equity manager or specialist whose duty is to attend and support community activities and programs that align with healthcare, education, and outreach?
I would say that is a great place to start. Yeah, it's a great place to start, because at least you have somebody who has that within their scope of responsibility. But I will also say it's not enough, right? It's just not enough. One person, and putting the onus on one person who will likely be a person of color from that community, and probably not, maybe not be somebody who is as acclaimed as other individuals in terms of their own respect in the profession and such. Right? And so that alone isn't going to work. But if you don't have one, it's a good place to start. It's a good place to start. But that needs to be funded. There needs to be a plan. There needs to be some goals organizationally for how this person is going to be used. And this person also has to have some kind of power to implement these things. So many times I've seen these individuals get hired within institutions and then they're handcuffed, and I don't understand what the purpose is then.
Okay.
Right. The person who asked the question wants us to make sure to say that she loves Dr. Spencer. He's blessed me with useful knowledge today. Thank you, in all capital letters. So that's a blessing.
Here.
I was gonna I'm gonna just dive in and ask a question that could be a real hot button. It could be a real trigger word. And that is white supremacy. So as a white person, what I'm feeling and seeing is people are much more open to talking about, after watching 2020, everything that happened in the summer 2020 and the convergence with COVID, I'm watching people who are white becoming more comfortable, more aware, even, reading books, talking, conversations. But the word white supremacy is a really, that phrase, whew, that's a hot one. And, I'm starting to be comfortable saying, if you're breathing, you're biased. So that's what I tell everybody. If you're breathing, you're biased. I'm getting more comfortable with, it's not enough to be not a racist. You've got to be anti-racist. I need help as a white person hearing that phrase white supremacy, because I see burning crosses in sheets. And I don't participate in either one of those practices. So help me with that phrase, because I am hearing scholars use it in a way that I think white people need to be educated what it means.
I agree. I think part of using the phrase for me is to start to normalize the phrase, because I think it has been something that has been associated with only the most extreme racists, only the most extreme forms of racism. And I think, so I used to do work with an organization called the Northwest Coalition Against Malicious Harassment. And our organization was specifically to monitor hate crimes and specifically to address um, groups that were considered to be white supremacist groups, and so that is the image for me as well, because that was my job, but in doing that work, one of the things that I also realized was that most of the people in those communities did not support those organizations, and many of those individuals were largely just compliant. They were largely just individuals who didn't want to make a ruckus, who didn't want to, who didn't want to get involved, who felt it wasn't about me, and so wouldn't act, right? Wouldn't do anything. To me, you are supporting white supremacy, okay? I mean, that is supporting it. If you do nothing to stop it, you're aware it exists. You do nothing to stop it, then you're part of a white supremacist system. You're part of a system that supports white supremacy. That has, I've always viewed it in those ways because, if we just look at the most extreme forms of racism, I don't think that that is where most people lie. In fact, most people would abolish those kinds of views and those kinds of actions. But it's really the compliance, that I think we have to address and attack, and we have to make clear that that is directly tied to white supremacy, and I think some of the backlash that we've seen over the past 4 years or so, I think it's been a difficult time for people. It's been a difficult time because I think a lot of people have been confronted by this new reality, but they're still not willing to take full responsibility, and they're still not willing to act. They may be willing to stand out on a street corner with a sign, but we need more than that. That's a start, but we need more than that. And I think we need to call it what it is, and we need to say, look, your actions support an extreme form of racism that we want to abolish from society, And if we can abolish those things, the way to abolish those things is to abolish those things in our everyday lives. I used to say, less so today, more so back then, I'm not really afraid of skinheads, because on an everyday basis, I don't interact with skinheads. But my neighbor who lives across, who lives just next to me here, felt very inclined to call me a piece of trash because my dog was barking excessively because it was hot and I left the windows open for the dogs when I was out. And he, who never sits on his balcony, happened to be sitting on his balcony that day, And again, okay, he called me trash. If he called somebody else trash, would someone else have the same impact, right? It would have the same impact on other people. Is that an act of white supremacy? Well, I question whether or not he would have called me trash if I were a white male, to be honest with you, I have to question that. And if I have to question that, then yeah, I'm being affected by white supremacy. You know?
Well, thank you for that. You really, wow, you really you really made me stretch today. Past some of the things I thought, wow, that's great, we're making progress, and realize, oh, that's just a start. So you really helped us today, and I thank you very much. And our time is up, and I'm going to ask Carla Bautista from External Affairs to join us. And thank you. I know that everyone joins me in thanking you, Dr. Spencer. Thank you very much.
Thank you so much. It's been an absolute blessing to be here. I really appreciate it. And go Bears.
Well, we would like to thank Dr. Spencer, our moderators, Dr. Body and Dr. Barron for asking these questions, and to y'all, our participants, for listening, for being here, and just wanting to learn more. Before we end, I want to go back to a definition I missed at the beginning. So what is social justice? We talked about it. Dr. Spencer talked about it. Social justice is a view that everyone deserves equal rights and opportunities. This includes the right to good health, to assure that everyone has the opportunity to attain their highest level of health. We must address the social determinants of health and equity to achieve social justice. And I hope that definition is encompassing, and it might not be, but we're all learning together. We're all working towards making sure that we are doing our part to achieve equity wherever we are. Unfortunately, this is the last presentation for this series, but we're looking forward to future presentations. We have had great speakers, and you can always go back and listen to the past presentations on our website. And before we end this presentation, I wanted to just remind you that if you are a Baylor ID holder, you actually get a discount when you visit some of our local businesses. And supporting local is not just, keeping money in our local economy, but it is to, support our neighbors and ensure that, we are doing our part to redistribute resources in our own community. So again, I would like to thank everyone for being here, and we'll see you next time. Have a good afternoon. Goodbye.